We are recording pending. We're recording now, so off you go.
Okay, good evening. Welcome everybody. Welcome to this Pan Midlands HST event, which we hope is as much a listening event as a speaking event. We're aware trainees have had a terrible time the last year and a half for obvious reasons. We're aware there's lots of anxiety out there. We ran two similar events for core trainees a couple of months ago, which were well received. We thought higher surgical trainees are more complicated and different group. So we're having two events, one tonight and one on Monday coming for higher surgical trainees. We've got a great faculty for you. So if we start with the basic housekeeping rules that you can see on the screen, because we're running this as a Teams event, everybody's here and everybody's live. So if you're watching a delegate, please could you have your camera off and your mic on mute. If you want to ask anything to any of the faculty, type away in the chat bar and we will address them when speakers finish and as seems appropriate during the evening. And obviously turn off your phone, shut your door, do all the stuff. We hope to finish when the conversation dries up, so definitely by 8. We're mindful many of our colleagues are on Ramadan at the moment, but definitely when the questions are done, we'll finish. So to start this evening, I think the key person I have to say, who's known in the West Midlands as the Wizard of Oz, is Usman Ahmed, who is the digital TPD for the West Midlands, and he's facilitated this whole evening, set it up in adversity, despite lots of obstacles, and has facilitated the thing forward. So many thanks, Oz. This evening has been coordinated by myself. I'm Jill Tierney, Head of School of Surgery in the East Midlands. Somebody has just typed in to say they can't see the screen and they're waiting for others to join. So if we could help them out perhaps in the background, we will get to you, thanks. With me is my fellow head of school, Tim Graham, head of School of Surgery in the West Midlands. And we've invited various people who we think will be of use. So please use this opportunity, ask anything. They're here to answer your questions. So to start off with this evening, we have 3 national big hitters. We have, as our first speaker, we'll get to in a minute, John McGregor, who is the chair of JCIE. So that's the exams regulator. So anybody doing FRCS in whatever your surgical specialty, if you have a query, he's the man to ask. Then we have John Lund, who is chair of JCST. And so he will interact with your various specialty advisory committees and is involved in the curriculum development and the new curriculum coming in and novel means of assessment, and also strong links with ISCP. So any questions around those areas, please submit and we'll direct to Mr. Lund. And then we also have Phil Bright, who is Head of School of Medicine in the West Midlands and a clinical advisor to HEE. So anything regarding your schools, so anything about your ARCP process, placements, COVID extensions, that kind of question can be directed towards Dr. Bright. In addition to that, this evening, we have 5 TPDs, and this evening we're getting input from general surgery, plastics, cardiothoracics, vascular and paediatric surgery. So if those are your areas, please submit questions to those TPDs and it will be Pan Midlands. So you may not see a face you recognise, but they will have the same degree of knowledge as the person you do recognise. So with no further ado, from lockdown, from a hotel in Glasgow, actively doing one of the FRCS exams as we speak, and on a curfew, so he has to get his dinner at a reasonable time this evening, otherwise the hotel restaurant will stop serving due to COVID. I'd like to introduce John McGregor. John, over to you.
Right, thanks, Jill. I hope everyone can hear me all right, and I'll share the screen in a moment. Yes, the tie is on because that's exactly where I am. Jill makes it sound as if I'm in a prison in Glasgow, which some people might want me to be in, but there we go. So let me just share, and I'm going to talk you through a little bit just of where we've got to with exams and where I see the direction of travel over the next 18 months or so. I am hoping that everyone can see that screen. It should be on share. Is that okay? Is it, Jill? Yeah. Okay, so if I move where we are, well, section 1, you will all be aware that section 1 is a computer-based test predominantly delivered through Pearson VUE centres. We had to, like all other college exams, suspend activity between March and the end of the summer last year. But very happy to report that since November, which were the second series of Section 1 exams last year, We were able to run them, and we have continued to deliver them since, as per the published calendar. We have a small number of candidates for dyslexia reasons need paper copy exams, but we were also able to deliver these. We were very fortunate in engaging with Pearson VUE to get special status that allowed us to keep the centres open during lockdowns, fire breaks, Tier 4 status in Scotland and whatever. And the Pearson VUE were also very good with their capacity and allowed us to accommodate not only the candidates who were displaced from June and July last year, but all other trainees who became eligible courtesy of ARC-P progression between August and October of last year. So the same arrangements have been in place since the second series of February this year. We did all sorts of measures like issuing supported travel documentation to candidates, and in many instances the Pearson VUE centres were only open for JCIE candidates. There were not the usual driving test people there. And as again, as all TPDs will be aware, an ARC-P 10.1 does not and still does not preclude entry to Section 1. Section 1 format did change in January of this year. That's quite separate from COVID. That was an agreed progression. It was with consultation with all stakeholders, GMC approval done well over a year ago with the usual year's notice of introduction. We moved away from one SBA and one EMI paper to two SBA papers in keeping with the vast majority of other high stakes examinations. So that was a separate COVID initiative and happened in January of this year. What we had to do to modify our Section 2 exams, however, I won't go into the great detail of the sort of evolution of all the discussions of last year, which increased the grey hairs that I have. But as we had hoped to sort of move initially to a socially distanced exam, the big premises, then to reduce number of patients when the surge in COVID cases in the autumn at relatively short notice, I went back to the GMC and we took patients out completely. So that essentially left us with any oral stations, and that includes urology, the entirety of the exam, with absolutely no change whatsoever to that component, with much the same as everybody's aware of, paired examiner designated topics. The only difference is we didn't have any examiners in training, and we didn't have observers, and we did not put assessors at the table. That's not to say, I've always assured candidates, does not mean that the examiners were not being assessed. They were subject to the same reporting and comparisons of how they were marking in relation to their co-examiners and the entire examiner cohort. But it was all about reducing personnel at any one table. The clinical stations were the issue, so clearly we could not ask and nor would we get volunteer patients. So we replaced all clinical stations with scenarios. The boards did a power of work writing clinical scenarios, supplemented by props, pictures, whatever else to deal with that. And we used a bit of examiner role play for communication and consent, but obviously no physical examination. But one of the most common questions I got asked last year in various fora was why not go completely virtual or remote? And I'm aware that some colleges have done this. A number of reasons, really, from our own perspective over here. Question security, mark sheet security, the sheer volume and number of candidates and administrations would be difficult. But again, all trainees or all candidates might not be aware of this. An integral component of all Section 2 exams is getting the examiners together, not just for briefing, not just for equality and diversity updates, but they spend a lot of time doing question calibration to get the standard right. Now, if examiners are all remote, it's extremely difficult to do that. You might get away with it in some of the smaller specialties like paediatrics, but when you've got trauma and orthopedic surgery, we've got a Section 2 diet this weekend with 144 candidates and 70 examiners. Trying to do that remotely is exceptionally difficult. And in the longer term, there's the examiner recruitment and retention. Examiners, apart from their own pleasure and their feeling of contributing to the profession, there's no benefit, and most of them have to pay back the time taken away for exams. But from the candidate's perspective, if we had gone remote, we'd have restricted the numbers considerably. I am doing I'll talk a little bit about remote examining, the remote connections to Dublin, because Irish candidates would have to quarantine and return with travel. But there's also sort of issues of demonstration of competencies in a higher order thinking of exam. So we still see, and not just through COVID, but going beyond it, that face-to-face examinations are the way ahead for JCIE. It's not a change to a remote exam. So this is what we did do once we restarted in November. November seemed a great choice when the presidents told me in the early part of last summer, you should not think about doing face-to-face exams before the end of the year. And then, of course, as we went through October, numbers were rising. And in the midst of all of these exams, England went into lockdown, Wales went into fire break, Ireland was shut down, and Scotland was in Tier 4 status. But we did examine 474 candidates in Section 2 exams between the 1st of November and the 9th of December. And all but 34 of these were done face-to-face. The remainder was where the remote ones, as I'll come back to. They were done between the Crown Plaza Hotel in Glasgow, which is where I am sitting right now, and the Royal College of Surgeons in Edinburgh. We did paediatrics and urology in Edinburgh. A lot of work was done with Scottish Government, Public Health, the hotels, the college, and whatever. And really, it was extremely pleasing that we did not cause a COVID outbreak. I think I sat at the end of October after many sleepless nights thinking if I get through the next 6 weeks without a problem, I'm going to be extremely lucky. But we did. And I think it's a great reflection on the professionalism of the candidates also, who complied with everything that we had put in place. And we had 2 candidates withdrew, one who appeared on site but phoned us in the morning and said, look, I've developed some symptoms overnight, and didn't appear. So really, that was extremely pleasing that we got through that at a time that many, many other colleges were either significantly modifying exams or not running them at all. The important thing is to stress, and I make a point of saying this to all candidates at the briefings that I go to, that the standard of the exam is unchanged. It is still the same exam. Please do not think you're getting a second-rate FRCS exam, and I can show you some data to back that up. So the preparation would be as one would normally do. So to back that up, I'm just going to show you details of one exam in particular, which is the biggest one, and then some comparative data from the other exams. This is the reliability data from the trauma and orthopedics exams for 2 full years preceding COVID, and then in the red at the end, the comparable figures for the November 2020 no patients whatsoever exams. So we've got 3 key stats: the overall reliability, the Cronbach's alpha, 0.87, absolutely in line with the previous 3 years of exams, the previous 2 years. Standard error of measurement less than 5% is the key for a high stakes exam. Again, 1.88, well under that, and indeed lower again than some of the previous traditional ones. And the inter-rater reliability reflects that it's always paired examiners. Greater than 0.6 is what you're looking for. There again, absolutely on par with things previously. And we've dug down into finer detail and looked at what would be traditionally called the clinical stations, and they have performed exceptionally well and contributed to that overall reliability. So just to show you some of the others, the message is the same, and it really is the same. General surgery, vascular surgery there, plastics, otolaryngology, and cardiothoracic surgery. I'm going to just put some of these up just now. The only one that was slightly below par and only minimally so was paediatric surgery, but there were only 9 candidates in that exam in December. They had had an exam just before lockdown, and there hadn't been a Section 1 feeder. There were predominantly resets, 9 candidates. You cannot read too much into that, and it was only minimally down. So I sat having many sleepless nights in October, thinking of what was lying ahead. I had a very large gin and tonic at the beginning of December, very satisfied with all of this, thinking we were through the worst. And then, of course, we all know what happened throughout December into January. And sadly, we had to cancel general surgery, trauma and orthopedics. I did that just before Christmas, because the worst thing for me is to see candidates preparing for an exam only to have the rug pulled from them below their feet at very, very short notice. And I was aware that had happened in some other colleges. And then when we moved into the new year in the middle of January, we cancelled the plastics, well, I should say postponed rather than cancelled the plastic surgery, oral max, paediatric surgery diets from the end of March. And that was the plan that we had then. And we really expanded in that. And this is the plan we're now working on. We delivered neurosurgery at the end of March in Edinburgh. We did oral and maxillofacial surgery last week in Edinburgh. I am currently at the ENT exam. And then the T&O diet that's starting this weekend was the scheduled second T&O diet of this year, but we put all the February candidates from there and then moved the ones who had already entered for April into a revised diet. Here it is down here at the beginning of June. So essentially that's what we've done. We've moved everyone forward, and we're running the same number of exams as we would normally do. And essentially it pans out like this, that instead of running between early February and late May, which would be the normal JCIE calendar, we are run between late March and early July. It's probably fair to say that we have a waiting list at the moment for the general surgery exam. That is the only specialty. I think we've now got a waiting list of Section 2 candidates. The replacement Section 2 diet, if I just go back to the previous slide, that we've put in for general surgery here in July. It's getting into summer breaks when people were hoping to get some time away. It also clashes with the Association of Coloproctology, but we really could not fit it in June, especially when we've got a big general surgery one at the end of May. And general surgery is a little bit more complicated to run because there's a special interest component, so you need to make sure it's not the total number of examiners, it's the correct mix. Colorectal is always the biggest group, and you've got AGP on at the same time. So there's going to be a little bit of a wait. There's about 24 candidates at the moment, but having said that, that is not any significant difference in what our normal would be. I mentioned remote assessment. We did 34 candidates in November, December remotely. These were candidates, all but 2 were candidates in the Republic of Ireland because of their need to quarantine on return. The Republic of Ireland does not allow, still does not allow people to travel from the UK without quarantine. We also said that we would take women in the 3rd trimester of pregnancy, and we examined 2 in that category in November. These exams weren't done from home. The Irish candidates were in RCSI, invigilated by JCIE examiners. The 2 remote pregnant women were in education centres, one in Sheffield, one in Cambridge, again supervised by JCIE examiners. And we did them as part of the schedule. We did them by Microsoft Teams, as I mentioned earlier on. So that's where we were. Obviously, every aspect of examining and curricula have to be approved by the GMC. And I have to say my understanding of the GMC is much greater now than it was at this time last year. And I think I would say the same vice versa. But we did agree, because of the very short notice of the change in examination format, which was really only done in early October, November, December, when we took patients out completely, we agreed that the attempt, if for any candidate happened to be unsuccessful in that first series, it would not count towards the normal maximum permitted number of attempts. This is Section 2, until we could demonstrate reliability. But moving forwards, I've shown you we've done that. The candidates have now got notice. The examiners have good experience, so the attempts are now counting, with one exception. Well, it was the MaxFax exam that was last week. The MaxFax had an exam again just before lockdown, no Section 1, and there were only 2 candidates waiting, so we could not run an exam for 2 candidates. At the back end of last year, we had to wait on the Section 1. So we did the same for oral and maxillofacial surgery last week. The attempt would not count. Where do we go from here? Well, clearly, I think the world has changed. And if anyone were to think that we're going to get back into clinical centres to run our traditional exams, the T&O exam I'm talking about this weekend, 144 candidate using 70 plus patients and 70 examiners, that's just not going to happen. We're not going to get anywhere near clinical areas. So we were looking at a change proposal to modify the exam, also taking into account the curricula changes, which are going to be discussed further this evening. And I put a proposal to the CAG group in January for submission, discussed in the March meeting, after a lot of work again done, board chairs for hybrid type exams, where we're basically reducing the number of patients to concentrate their presence for professional skills, bearing in mind that the multiple consultant report and the enhanced workplace-based assessments will complement the exams, and we work together very closely. New exams were linked to the new curricula. This went to the GMC, as I say, in January. I had feedback last week, which is extremely positive from the GMC, just 1 or 2 loose ends to tidy up, which we will publish prior to August this year, with a plan to implement in September of next year. again allowing for the year's change notice. And one of the more important things to stress that these exams will not take place in hospital settings, which will allow us to go for centrally placed venues, drastically cutting down on travel time and costs for many people, examiners and candidates alike. The GMC have said to us in reply that they do want us just to continue with the current format that we're running through until that change next year, assuming we approve everywhere. And I think, there might be some people that feel, well, why can't we get back to patients before that? But I think the worst thing for candidates preparing for exams is uncertainty and chopping and changing. We have shown that we can run this COVID format, whatever the pandemic throws at us. We're not out of the pandemic yet. We're potentially in trouble again next winter. I wouldn't write that off. So to say to candidates that we can run this exam in the most difficult of circumstances, we will continue to do so, and it allows JCIE to organise with that in mind. So I'm going to stop at that. I'm very happy to take any questions, and I'll come out of share in a second.
That was excellent. Thank you very much, John. We really appreciate you doing that whilst doing the exam. There are some questions being typed in, and we also got some pre-submitted ones. So the first thing we can see in the chat bar, thank you for the detailed presentation. Is there any provision for accommodating more general surgery, particularly colorectal, as you said, a big group of candidates in May or July? There's somebody who's on the waiting list and it's going to affect their CCT date. So have you got any extra capacity plans or?
There's nothing we can do to increase the capacity from what we have, Jill. We've got 137 candidates at the end of May, which is bigger than normal. I think we're about 80 candidates is the size of the exam in July. I appreciate the difficulties. We have notified all candidates and asked them, because you're an examiner, and when you get to an exam that you have what we call buys, because they're late withdrawals. We have written to all candidates to ask them, if you're going to withdraw, can you please consider your fellow candidates and give us as much notice as possible, because then we can reallocate that slot. But when it happens a day before, or even a week before, the schedules are done. And I say the general surgery is a particular difficulty because of the special interest. You can't just have someone who's a breast surgeon examining a colorectal candidate. Appreciate the difficulties, but I think we're doing as best as we can, and we will continue to adjust that list as we can.
Sure. Okay, that's great. Another one pre-submitted, and you've answered these mostly during your presentation. So changes in the Part 2 FRCS has caused a bit of confusion with some newer items put in. Somebody who did paediatric surgery exam felt that some of the scenarios seemed a bit rushed in their preparation and perhaps a little unrealistic. Do you have any comment on that?
I can't specifically comment the scenarios, not being a paediatric surgeon, but I know that Larry Cusick and David Crabb, the previous board chair, did do a lot of work on that. Yeah, I think it was, again, I would say that first diet didn't count. Like everything, we always review afterwards. We look at the psychometrics, we take feedback from examiners and candidates into account.
So an acknowledgement it was difficult, but that's why it didn't count. And yeah, we've learned lots. Okay, what are the schedules for the Part 2 FRCS T&O exams in the next 12 months? I think you've put that up already, haven't you?
It should be exactly per the calendar moving on, unless we get similar issues that happened earlier this year. So T&O will run again in November. It should run in February next year and in April next year. That's the normal. T&O in general surgery have 3 diets a year because of the numbers of candidates. The other specialties, it's 2 diets, so section 2 a year.
Okay, you've answered this as well. Will the examinations return to their normal format next year?
No, we will not return to taking over entire outpatient areas, entire day surgery units, whatever it might be, with 200 plus people in there. We are not going to get that. The service is going to need every bit of capacity it can to recover from this, and I don't think your patients would volunteer anyway.
Sure.
So, and another, I think it's time to move anyway with the new curricula.
Sure. A lot of questions from T&O trainees, particularly, obviously, about the format. And I think what they're asking is, what about patients in Part 2, clinical examination patients?
Well, I mean, what I would say to that is that this is an exam that's taken in ST7, ST8, or it'll be phase 3 come August onwards. We don't assess technical skills in an exam. apart from one specialty who did it years ago, and that's since long gone by the wayside. But we don't assess technical skills. Is it appropriate to suggest that a single snapshot of a T&O candidate examining a knee at ST8 level is an appropriate assessment? Now, you know, there's something wrong with training and workplace-based assessments if they're not doing that by that time. I think it's different matter MRCS level. I think we're concentrating in higher order thinking, non-technical skills, and partnership with JCST. With the multiple consultant report. I think that is the way forward, not single snapshots that somebody could do themselves more damage than good in times.
So that's a very clear answer. Compared to the past FRCS, there's a feeling that this year going forward, some people will score higher because they've had loads more time to study. Other people have had massive disruption to their personal lives. Is there kind of adjustment, a standardization process happening to results?
We don't adjust results in section 2. There's a pass mark. It's an average of 6 in every marking episode across the exam. It can be achieved by any manner of means. There's calibration done the day before, which is what I was mentioning about the examiners gathering and agreeing the standard. I think the GMC have taken a very and quite reasonable review that they view that the standard of assessment is not to be altered. We would go back to our own guidance notes to candidates and applicants. It's the candidate's responsibility in conjunction with the referee to determine if and when they're ready to sit the exam. But there's no post-examination adjustment of the standard at section 2. Section 1 is a standard set exam, but as it always has been. But we've not altered the standard.
Okay, so those are the typed in questions we've had from delegates. I'm conscious we've got a great panel here. I don't know if any of the panel want to ask John something while we've got him captive. I know, Tim, you've had a big role to do with examinations. Do you want to ask John anything in front of the audience?
No, I just want to support what John and JCIE have said about the exam needing to develop and move forward as per the curriculum, and a final exit examination in a surgical specialty is not the place to be checking that people can do essential basic clinical examinations. And I think we just need to make sure that we're delivering appropriate workplace-based assessments in the schools of surgery.
Okay, we've had an additional written question about the JCI website. Can it add the exact format for this year's part 2 to the website, because they can't seem to find it on there?
Yeah, it's. I think it probably hasn't changed, Jill, because the actual exam hasn't changed in terms of structure. It's the same number of stations or sections. So you've got the 4 orals and the 2 clinicals, but the clinicals are in inverted commas with scenarios replacing patients. So exactly the same number of marking episodes, exactly the same time, exactly the same examiners that are exposed. The only difference is, say, there's no patients, and it's a simulated patient rather than a real patient being. That's slightly different, say, from MRCS. The OSCE, Part B OSCE MRCS did reduce its number of stations to allow it to run in the COVID area. We have not altered our assessment process as such.
Okay, I think that's clear, isn't it?
I would say that within the next couple of weeks, I will be communicating out to all candidates, because I was waiting on word from the CAG to give our direction of travel for the next 18 months. And now that I have that, I am planning to do one of my communication exercises, which will go out to everyone, all stakeholders, to say this is our plan now moving forward for the next 18 months.
Okay, so while we have our TPDs, I don't know if any of the TPDs speaking tonight would like the opportunity to ask John anything while he's live for his session. It's okay if you don't, if you feel your trainees have asked.
Jill, I can also see that there are TPDs in the attendees list as well that are not necessarily speaking this evening. So again, if any of those have got any queries, please please identify that now.
Okay, well, I'll stay here, Jill, and watch questions and answers. I must say I might have to disappear about 7:30, but I'm here for a while.
That's great. Thank you very much for that, John. Much appreciated. Type in the chat bar about exams if something comes to you. So moving on, we're going to go, I'm not going to make any jokes about hair, to the chair of the JCST, John Lund, who's going to talk to us about all things curricular, I think. Thank you, John.
Oh, thanks very much. So I was asked to keep it brief. So a bit like John, I'm very happy to take questions at the end of this and through the rest of the webinar. So I'm going to talk just about a few general things. COVID, the impact of COVID, what we hope for the recovery, and the new curriculum. So next slide, please. It's winding up. Okay, so this, I'm just going to show you some graphs now. This is what happened with COVID. You can see the logbook numbers taken from eLogbook for each of the specialties, and we'll go through them each in turn slowly, but you'll see how remarkably similar all the curves are. And funnily enough, they're the kind of inverse of the prevalence of COVID at the time. And they go from December 2018 to March 21, and these are taken directly from each thing. In each curve, the blue line is elective cases, the red line is emergencies. So you can see here cardiothoracics and ENT. I used to put a line on that said when COVID started, but it's so obvious, I took the line away. You can see there in March 2020, there's a huge precipitous dip in the number of cases performed particularly electively, much less impact on emergency, with some recovery through the summer, but in no way back to the pre-COVID baseline levels. And then with the second wave, a massive dip again, but we can see the crocuses as recovery, as Boris puts it, starting to appear now. And the last 2 months, we've seen an increase in the number of cases accrued in logbook. So there's cardiothoracics and ENT. If we go on to the next slide. We can see general surgery now and maxillofacial surgery. So general surgery has quite a lot of its caseload as emergency surgery, but even then there was a dip in the early days of COVID, as it was only lots more cases were handled conservatively rather than operatively, but that's pretty much got back to baseline levels. Next slide. Neurosurgery, huge dip in their elective cases, because neurosurgery, of course, is one of those specialties that is ITU dependent, pretty much either for its neuro or its spinal work, and so pretty much dipped to zero in the early days of COVID and has been hugely affected by COVID. Paediatric surgery there, similar pattern. Next slide, please. Plastic surgery, a dip in both the emergency and elective. Trauma and orthopedics. Again, no cancer work, or very, very little cancer work in trauma and orthopedics. So a massive and sustained impact on elective work because of COVID. Next slide, please. And then urology and vascular, both showing very similar patterns. Again, vascular surgery, a high proportion of its workload emergencies. OK, so move on to the next slide. So you can see there a massive impact of COVID. If you just think about the areas under the curves at the various points, there's much less activity this year. And we think that overall activity, certainly coming up to Christmas, was down by about 50%. So what impact has COVID had on ARCP outcomes? Well, this is the last record we have pre-COVID. These were all the ARCP outcomes in surgical training that were registered in ISCP at the end of February 2020, so immediately before COVID. And you can see the dark blue is ARCP outcome 1, the keys at the bottom there, outcome 2 in orange, outcome 3 in grey, and 4 and 5 you can see. But you can see apart from the CT2 and ST8, most of the outcomes are ARCP1, and a lot of the outcomes in CT2 and ST8 are, of course, outcome 6, so leaving a program. If you contrast that now with the next slide, which shows the ARCP outcomes at the end of March this year, which is the last month we have data for. And new on the slide are the outcomes 10, which came in from the statutory education bodies not long after the COVID became a big problem, and has been very helpful, I think, in training. So outcome 10.1 in green, outcome 10.2, so in dark blue, outcome 10.1, equivalent really to it's a no blame outcome, both of these, but equivalent to an outcome 2. You haven't quite got to where you should be, but the training time doesn't need to be extended. An outcome 10.2, a bit like an outcome 3, but no blame, that training does need to be extended. And you can see that different specialties listed there with core at the bottom and vascular surgery at the top have been affected to different extents. You can see the most affected specialty is about 40% of trainees, and outcome 10 of some kind is trauma and orthopedics, which probably reflects that massive impact of COVID on the elective non-cancer work of all specialties, which is particularly affecting trauma and orthopaedics. One of the downstream effects of this is the move to get some extra capacity to independent sector providers, and of course trauma and orthopaedic elective work is one of those things that's most likely to move, and this is where the biggest deficit is, both in casework in logbooks and also in ARCP 10.1 and 10.2 outcomes. So it's absolutely imperative that we have a sustained and an easy access to any independent sector provider, whether T&O work or any other work might go. Next slide, please. So what are we going to do about it? Well, we're starting to recover from COVID now. For the time being, I'm touching all the wood that I can find in my university office, which isn't much real wood. You might remember that in the back end of last year, we issued a document called Maximising Training Opportunities, and that was starting to look a bit tired and out of date. So we have just updated this and just about to publish this on the JCST website. It's a joint document developed with ASSET and BOTA, the Confederation of Postgraduate Schools of Surgery, and all 4 surgical royal colleges. The main thing is it's train at any time, in any place, on every case, with no excuses. Next slide, please. So you'll see the document when it's published very shortly, but it has these main headings. This COVID impact is everyone's problem, from employers, colleges, trainees, trainers, schools, statutory education bodies, the public, the NHS. It's everybody's problem, so everybody needs to be part of the solution. Everyone involved in surgical services has a part to play in the training recovery. And I think that consultants need to remember that all consultants were trainees at some point, and all consultants can train. In fact, it is point number 36 in Duties of a Doctor, the GMC document, that all doctors should train and teach. And so there should be no ifs or buts about training. There should be no dodging training. There should be no shilly-shallying from consultants. Everyone was a trainee once. Everybody needs to be trained. Nobody was born a surgeon. There's no case that isn't a training case. Now, we didn't do last year's work, and we need to do last year's work this year. And there's about 4.5 or perhaps more now patients waiting for treatment. And so every single one of those should have at least one trainee involved in their care. If we can get a trainee involved in the care of each of those patients on the waiting list, then we would get back to where we should be very quickly. There's no operation that a trainee can't do at least part of. So no more standing around watching, being second or third assistant. The mantra should be from trainees, can I do that? Which part of the case can I do? And consultants should facilitate access to all cases. And you can maybe not do the whole case, or if you've got true trainees there, then divide the case up between you. If there are 2 consultants operating there, that's an ideal position in which to train, because you can share the work, and it's a very, very easy time to train. And then we also have to remember that logbook numbers easy to gather and show on graphs, but it's not just the only area that's been affected. Emergency work probably has remained pretty much the same for most people, especially those people that have been lucky enough not to be redeployed, but the impact on outpatients, on going to the MDT and other specialty activities has been impacted by COVID. And so let's not just think about operative cases. We have to train to be surgeons across all the things we need to do to be surgeons. Okay, next slide, please. So the other thing I wanted just to cover briefly is the new curriculum. So there are 105 days to go from today before the new curriculum starts. Next slide, please. There's some changes. It's the biggest change really in the curricula since 2007. And the major changes are the curriculum is going to become outcomes-based, properly outcomes-based. So you can finish training when you're ready to be a day 1 consultant, and the day 1 consultant is defined in the syllabus of your specialty. All the curricula encompass the generic professional capabilities. So these are the things that the General Medical Council say that all doctors should be capable of before becoming a doctor, be you an oncologist, surgeon, occupational health doctor, consultant, whatever, and the capabilities in practice, which are the areas of work that all surgeons do through the week. So these are things like the MDT, a ward round, managing theatre, managing outpatients and emergency care, and they're the ones shared between all surgical specialties, and some specialties, your specialties of plastics or paediatric surgery or cardiothoracic surgery, might have a couple more in there which you can find on the curriculum. But those are things that all consultants will do through the working week, and so you have to be capable to a level of a day one consultant obviously across the board to be a day one consultant in your specialty. The good news, there will be no more mandatory workplace-based assessments in a year, so not 40 or 80 depending on where you work, and a few will be retained to underpin competence in index procedures and critical conditions. So those are the things that really are the absolute centre of your specialty, and so you need to get 3 outcome level PBAs, appropriate PBAs in the index procedures and the critical conditions. You can find those listed in the appendixes of your specialty curriculum. What's new is a multiple consultant report. So this is a report that will happen halfway through placement, towards the end of the placement, that those people who you work with, those consultants you work with, will get together and allocate and decide between them a supervision level for how you're doing. So how you're doing relative to being a day one consultant, relative to the end of training. And from that, part of that report will provide bespoke feedback to you as a trainee on what you need to do in the next 3 to 6 months to get closer to being a consultant. And so you get, just by doing this multiple consultant report, much better feedback that you can talk about at your next learning agreement, perhaps change the focus of the placement halfway through the placement so you can concentrate on those things that will move you forward best. And you will also be asked to perform, if you're a trainee, a self-assessment, which goes to the same generic professional capabilities and capabilities in practice, so you can identify your own learning needs as well and take that to the learning agreement. So the learning agreement itself will be much better. Next slide, please. Next slide. There we go. So where to find this? So go to iscp.ac.uk. It's a website you might have heard of. At the banner at the top there is the carousel. The first page on that is the surgical curriculum. Click on that and it will take you to, next slide. Another page lists everything that you need to know about new curricula. If you scroll down a little bit, you'll find links to all the specialty curricula there. So find your own and go and have a look. I would encourage, as it's the biggest change since 2007, everyone just to have a look at their own specialty curricula to find out what's happening. Next slide. You can also now do the multiple consultant report. It's a trial version. If you're a trainee, you follow the links where it says trial MCR there in the top right hand corner of the page and perform a self-assessment, take that to your learning agreement. If you are trainers, you get together and perform a multiple consultant report for your trainees to provide feedback. It's going to be particularly important, one, to get used to this assessment tool, which is going to be coming in from the 4th of August this year, so 105 days away, but also to help people identify their learning needs post-COVID. So it will give you a bespoke plan, as I said earlier, to identify what's going to help you move forward for the next 3 to 6 months, and also pretty much identify the gap between where you should be and where you are now because of COVID. Next slide, please. So where to find out more? Well, here you go to iscp.ac.uk. You can follow those links or use the URL there. Next slide. We've run a lot of webinars and we're continuing to run webinars, but we're going to have specific drop-in sessions where you can register again through that curriculum page on ISCP for Teams meetings with Keith Jones, who's the ISCP Surgical Director, and ask Keith any questions you want to ask about the curriculum. There's lots of dates there and we'll be providing more through the year. So if you have a read and you're not sure, if you still have some unresolved questions and you've been unable to attend the webinars or have questions after the webinars, then you can go along and ask Keith directly. Next slide. Lots of webinars. We've been emailing people on Twitter and mention these on Twitter and they're on the ISCP website, but look out for those. And next slide. And there's videos and step guides and all sorts of resources available on YouTube on the JCST ISCP YouTube page. Next slide. Or is that the last slide? That's the last slide. So that's COVID and the new curriculum. Thanks very much for that. Very happy to take questions and I'll be able to answer questions through the rest of the webinar.
Okay, right, thanks. We do have some. So as with the core event, this is a no holds barred kind of an evening. So I've got a very definite, and I completely identify with this questioner actually. So they felt to Mr. Lund, the biggest limitation to surgical training prior to COVID really was elective opportunities. So elective lists are great, trainers are nice, it all goes really well, but you just don't get there because of the on-call rotas and providing emergency cover. So this is a West Midlands colorectal trainee who's on a 1 in 12 with other middle grades. Everybody wants a piece of the action, and you're lucky to get 2 elective operations a week on a good week. So what structure, how can we get around that, especially with the backlog and the need to recover?
So with the backlog, I imagine that the opportunities will expand, and that's about actively looking for these and timetabling. Extended surgical team that you and Tim are very much involved with is going to provide some help to release trainees from things to do on the water, release trainees for training opportunities, look out for things happening in the independent sector. And if you're not getting those opportunities, then speak to your AES, speak to your TPD. There may be opportunities elsewhere. If you're coming up to a critical progression point in your curriculum, and hopefully soon flexibility will be a lot easier, so you can move between centres for various things to get you over the line for the curriculum. So hopefully as the capacity starts to expand again, then opportunities will start to expand.
Okay, the process question, will ST78s be going on to the new curriculum or staying on the old one? So tell us the exact rules and dismiss all the hearsay.
Okay, so it is again available on that page where all the curricular information is. If you are starting on a new programme, so you are CT1, ST1 or ST3, you will start on the new curriculum. If you are entering the final year of your programme, so CT2 or ST2 or ST8 or ST7 if you're urology or facial-maxillary surgery, then you will continue on the old curriculum unless you choose to move to the new curriculum for reasons that might be advantageous or helpful to you, but that only in conversation with your TPD. If you are between those, so you're already on a programme and you're not entering the final year, then you will move to the new curriculum. If you are less than full-time, you can opt to stay on the old curriculum until you move over the year end of your whole-time equivalent. So let's say that you are coming up to 50% of your whole-time equivalent LTFT in August this year. You don't have to, you're not made to move over to the new curriculum until you get to 100%, which would be August 2022. However, less than full-time trainees are often way ahead of their chronological year progress through training, and so might find it advantageous to move earlier to the new curriculum than that, and so can choose to do so in conversation with TPD.
Okay, thank you for that. There's another one which has been asked in many different forms. So there's a new requirement for WBAs regarding, and we've talked about this informally, haven't we, about the critical conditions required for CCT. And so if you're halfway through a training program and you've done those attachments, for example, this is about cleft and OMFS, or presume it's OMFS or P's, under cleft anyway, and they've done those jobs where they would have got that, how are they going to get that at CCT?
Well, so there's been no change in the current. There's been no change in the current circumstances. So the critical conditions, by and large, for the curriculum are exactly the same as those existing at the moment, and trainees have always had to demonstrate competence in those critical conditions and index procedures by the end of training. Sometimes it goes past without doing that, and so it would be a question of catching up or going to a clinic or just having a training opportunity to do that. A lot of these, if they're if they're CBDs, can be done on a simulated page. You can talk about just about demonstrating the sensible knowledge and the management plan. So have a chat with your AES about catching up with those if they're not there. But essentially, there's been no change to the current circumstance.
Okay.
They've been retained rather than added.
Okay, as there were those helpful waypoints that were available on the JCST website before, are there the ST4, ST6 checkpoint checklists?
No, so they're not there because the structure of moving through the curricula, moving through the syllabus has changed. So there'll be phases of the curricula, and certainly with general surgery that's changed. But you can get a good feel of that from just dividing things into 2/3 and 1/3. The critical progression point for most specialties is going to be at ST6. The progression really is about how close you are to CCT. So what supervision level in each of the capabilities in practice that you're at, rather than the other areas.
Okay, I'm just going to ask, we've got Miss Chip, plastic surgeon here, who has more expertise in that specific area. Do you want to speak about that cleft PBA requirement, Liz?
Thanks. Well, only to say that actually, so Hattie is one of my trainees in the West Midlands, and unfortunately I couldn't tell her the answer to that question. So I think cleft is perhaps, certainly in plastics, is quite a unique situation because it is one of the indicative logbook procedures, one of the index procedures. But at the moment, trainees only have to show that they've observed the operation, because obviously it's a very specialist procedure. It's very difficult for trainees to physically operate around a small child having a cleft procedure. So if, as Hattie said, if they will be required to show those 3 level 4 PBAs, that actually will be a very big change for cleft. And I don't know, in answer to Hattie's question, how we will do that. I was considering joining one of the Ask Whoever It Was webinars on a Friday morning to ask just that question, because I think for cleft particularly, as an example I can think of in plastics, that'll be difficult. There might be similar procedures in other specialties.
So I know a local solution.
I think there then is to ask the plastic surgery SAC chair, because the particulars of the syllabus were developed by the specialty. So I think have a chat with Manny about that rather than Keith, and you'll get a definitive answer from Manny.
Okay. And I'll then hopefully pass it on to Hattie and the other trainees. Thank you.
And we're also trying locally Pan Midlands to get this concept of training passports up and running, because I know it's probably adult cleft. There's been an OMFS facility in the West Midlands that people have had facilitated 2-week attachments to, and they're keen to kind of restart that and spread it wider, because there'll be more of a need for that. So I think as long as we keep this kind of dialogue going, we're in a really lucky place as a smallish region. So a question to Mr. Lund. This is a clever question, actually. If there aren't any checkpoints anymore, then what limitations to when you can take your FRCS?
Yeah, so you can take your FRs, or you can apply to sit it when you have reached the end of phase 2 of the curriculum. So when you have a look at that page, you'll see that phase 3 for most specialties is indicative time of 2 years. So sitting that will be exactly where it is at the moment. And to get to the end of phase 2, you have to have demonstrated to the satisfaction of your trainers that you have the knowledge and the clinical skills, clinical professional skills, to be examined as a day 1 consultant. So there's very little change in actual fact. It's just a slight change in the wording.
And John McGregor completely agrees with you, which is really reassuring. I don't know if any of the other experts on the panel, rather than trainees, want to ask Mr. Lund a question while they've got him captive. Mr. Graham?
Just to point out, while we've still got John McGregor, I think neurosurgery is actually different. I think they've only got 1 year at phase 3. So they've essentially got a curtailed period of time to sit the examination, if my understanding is correct. Maybe you two experts can correct me if I've misunderstood. John McGregor?
I'll just come in briefly, put my camera on. Yes, John and I are aware of the neurosurgery issue. I only became aware of it about 3 weeks ago, and we have had discussions about it. We're sorting out the precise wording because they've only got an indicative 1 year, phase 3. It just needs to be a clear progression point, because we need to apply the same criteria to not in training candidates as we do to trainees, and it's work in progress, but aware of it.
And without stressing you too much, of course, the anticipation is that in the current curriculum at ST7 and 8, the candidates would get 2 opportunities in both years, which would use up their 4 opportunities, and would give them a reasonable shot at completing the examination whilst they were still in training time. Strikes me as a head of school that the neurosurgery curriculum is actually heading very much towards the trainees requiring an extra year at the end.
Just watching Mr. Lund to see if I can see chest pain happening.
think he's frozen.
I think he's frozen.
Yeah. Apologies, I've frozen the Professor Lund. Okay.
Excellent. Well, I've been trying for years. Right, we'll move on. So we now have our third big national hitter, and we have Dr. Phil Bright, who's clinical advisor to HEE. Thank you very much, Phil.
Thank you. I'll just share up. So HEE is absolutely and acutely aware of the position that many trainees find themselves in, given two significant waves of the pandemic causing disruption to experiential learning and challenges, as we have heard, over exams. That disruption to experiential learning is because many trainees were actually redeployed, but even if they weren't actually redeployed, there was a functional redeployment that happened, and that either the workplace that people were in changed and became very COVID focused, or they were asked to do different duties but still working in the same place, change of work schedules, work rotas, all of which meant that experiential learning went down. So not only did people stop progressing, in many cases there was a degree of regression in their previously attained experiential levels. This leads to a potential increase in not only the number of outcome 10.2s, but also outcome 10.1s. And this is expected to be seen in the upcoming summer ARCPs. We already are seeing that outcome 3 or 10.2s are running at about twice the level they were in the preceding year. So the impact is already there, and that reflects the effects of the pandemic from the first wave. Training recovery is going to take a long time to completely work through the system, and will probably still be with us not only in 21-22, but potentially in 22-23 and 23-24. There's a compound effect that we're getting here. So even trainees who progress on a 10.1, they haven't met all of their curriculum requirements. If they haven't met them or can't meet them, they may end up on 10.2 subsequently. So all of this has led to a quite extensive demoralisation and anxiety amongst trainees about their progression, but also amongst trainers. And people are tired. The loss of training progression will impact consultant numbers of people getting their CCTs, and could also potentially back up the training system. And there will be not only costs in terms of personal terms, but financial costs to the training system that need to be thought about. And we do need to think carefully about what the implications on future recruitment might look like, although that is something we absolutely want to avoid. And the impact is different depending on program, as we've just seen, but also different localities have been impacted differently, and it's not always apparent why a particular location has a greater impact. And then there's been a differential impact depending on trainees' own personal circumstances. The stance taken by the GMC, HEE, and the NHS in general is that we must maintain standards. Having said that, there's also an understanding in the system that when trainees come out of training, they have developed beyond what the curriculum requires and have attained other skills as well. And the question here will be whether that stance will be maintained, or whether people coming out of training will simply be curriculum complete, but not necessarily at the same level of service readiness that the service has become used to. We need to look at individual trainees and individual trainee risk, and we've done a lot of work to understand this. We undertook the training risk reporting tool, which many of you will have taken part in, where people reported what they saw as their individual challenges to their training progression, and that information has been vital in helping to shape the HE response, and is still being used now to try and influence the Department of Health and ultimately the Treasury. Those trainees most at risk are deemed to be those at critical progression points at the end of higher specialty training or the end of core programs. But there are within some programs other critical progression points, and we also have to take account of those too. Those trainees at risk may get a 10.2 and an extension, additional training time. But what does that really mean? We'll talk about that more. We need to identify for each individual trainee the particular issues faced by that individual, and they will be different from a colleague who is ostensibly the same. And we need to plan for individual engagement with individual trainees, both at a programme and a local level. Within localities, postgraduate deans have been working with heads of school, and each deanery, each local office in HEE should have nominated a training recovery lead. They've been asked to understand the impact by programme in their particular geography, but also what are the possible solutions that can be used. And we heard earlier about the possibility of trainees moving from their base placement to maybe do a theatre list or a clinic in another institution. That's always been very difficult in the past, but we're now seeking to overcome the HR barriers that make that more difficult. We need to get trusts to focus on training recovery and prioritise it. Otherwise, any recovery is going to be much more protracted than it needs be. And that might mean asking trusts to adjust their working practices. So that work with providers is absolutely critical, and something, again, that we're working closely on. In each programme, we've also been working with the Royal Colleges to review the curriculum decision aids and the derogations to curricula issued by the GMC. This is quite an intensive piece of work, but we're now getting into a position where those amended decision aids are ready for publication. Some of them have already been published. And we're looking to use our technology enhanced learning resources to help support people, not just simulation, although simulation is part of it, but also other technological enhanced learning resources, one of which we're obviously on this evening. And we've undertaken some national conversations with the different colleges and specialty leads so that we understand their position, and that has helped us to develop those decision aids. Training recovery, as I've said, is going to be protracted, and we need to make sure it happens as efficiently and in as focused way as we possibly can. If trainees need extra training time, we will be giving them extra training time, although we're going to do everything we can to try and avoid that if possible. It's not just about the post capacity for that extra training time, though, but it's about, is the experience going to be available to all trainees in an equitable way? This is going to be happening at a time of service recovery, and that itself brings challenges. And we're working hard to try and make sure that service recovery and training recovery don't clash. The most limited of the resources, though, is the supervisory capacity, and we can give trainees on extension the post to be extended into. They can have the experience in their own trust or in other trusts released to go and do training recovery experience from normal clinical duties. But the supervisory capacity is limited. We can't come up with a whole host of new supervisors, no matter how much we'd like to do that. Each trainee is going to be offered a one-to-one training conversation undertaken by the most appropriate person to do so. And part of that conversation is, first of all, assurance, making sure people are okay. What training have they been able to do? What training have they not been able to do over the last 12 months? And after that should come a training recovery plan developed at a personal level for that individual trainee. And trainees having these one-to-one conversations should have a realistic expectation of what their upcoming ARCP outcome will be, and then the training recovery plan to take them forward following that. There is this issue of capability versus confidence, and that in some situations, trainees who have previously attained curriculum requirements, because in the last 12 months they've not been practicing their craft, may well have regressed in confidence. So although they are technically capable, they have lost confidence. And we know that many trainees are aware of this and are worried about it. And there are options for such trainees. They can, for instance, take what's called an OOP-P. That's essentially pausing the training clock and stepping out to just do service delivery to regain that experiential confidence. Some trainees, particularly if they've been deployed heavily over the pandemic, may wish to go less than full time and to use that as a way of regaining their confidence, as well as easing back on the pressure that they've been under over the last 12 months. We need to make sure that those trainees on 10.1s are looked after as much as those trainees who have the requirement for additional training time, because if we don't, those 10.1s may well turn into 10.2s subsequently. And that means making sure that trainees on 10.1s have an early review to make sure they're progressing satisfactorily and bring in extra resources or to change their situation should we need to do so. Another way of addressing the capability and confidence gap is for trainees to take up periods of grace or acting up consultant at the end to give them that confidence that they can step forward as that day one consultant. So in summary, the effects of the pandemic have been widespread and will be long spread, and this won't be over for the next half decade or so. And HE obviously acknowledges the huge efforts of all our trainees and our trainer workforce across this time, and just the state that people have been left in following the pandemic. In the immediate future, we will need to sort out training extensions, and we need to do so without reducing recruitment, because that would be very, very unwelcome. And we do have to think about trainees who are curriculum complete but are not in the traditional way what was described as being service ready, and also those trainees who have lost confidence because they've not been practicing their skills over the last 12 months. We can try to do what we possibly can between now and the main ARCP season in the summer, but for many trainees there may well be a need for extended time, and we need to make sure that that extension time is used as efficiently as possible to get people to where they need to go.
That's great. Thank you very much, Phil. That was excellent. Specific one about the OOP, if you could. So is the trainee in an OOP classed as supernumerary? Do they go to another unit? Do they, in essence, find their own job? How's that work?
So it's a non-training job. It can be for up to 12 months. At the end of it, any skills that people have acquired will be assessed when they come back into training, and their experience will be then counted towards their curriculum progression. Trainees are normally expected to find their own job, but in current circumstances, heads of school and TPDs will probably facilitate them knowing their geographies as well as they do, and can point trainees and basically act as a matchmaker between trainees and trusts to help people into posts.
Okay, but they're off programme while they're pausing.
Yeah.
So a quick one, I've got one for Rob Williams here, actually. I can see you chomping at the bit, and it's for you, really. Colorectal surgeon struggling with endoscopy, new curriculum. How are you going to sort that out then?
Yeah, that's going to be interesting, isn't it? You've got to remember that there were issues with endoscopic training prior to COVID. So this has been a long-lasting sort of legacy of problem for GI trainees specifically. Add into that the new curriculum now has numbers for colonoscopy and upper GI endoscopy within it. So I think the first thing I'd say is I think that changes the focus of how important getting endoscopy training is through to the trainees as they work through. I think it's sometimes been a sort of very last minute consideration and difficult to reach because it's perhaps not been prioritised as it should have been in the past. So I think the new curriculum helps with that because it puts it on everybody's radar. I don't think there's going to be a panacea for how every region recovers its endoscopic training. I mean, certainly in my own region at the moment, we don't suffer from a lack of list. The lists are going on, but the number of units on each list is lower. But you could argue that actually, I mean, it's usually around air turnaround times, but actually that might facilitate training a little bit because if the lists aren't overbooked, and they're definitely not overbooked at the moment, then that is useful, I think.
Okay, but I'm just conscious we're getting out of time. We've got tons of information. So we have our 4 expert TPDs here this evening. I wonder, and we have a few more questions to ask. Can we start, please, with Miss Chip, who is the TPD for plastic surgery from the West Midlands, who's come to talk specifically about plastic surgery. Thank you, Liz.
Thanks, Jill. Hopefully you can all see my PowerPoint, although I can't.
Yes, we can.
Well, that's good because I can't. Hang on a second. Right, okay. Bear with me. I only have a couple of slides. It's a very brief presentation, but again, I'm happy to take questions at the end. So yes, I'm the TPD for plastic surgery in the West Midlands. I know quite a few of our trainees are on the webinar. I thought I'd just talk briefly, you've heard a lot of this already this evening, and none of you need telling about the negative effects of COVID and the pandemic on your training. So what I have found from talking to you all and ARCPs and looking at logbooks and things is that the effect, as we just heard from Dr. Bright, varies enormously between regions, between hospitals and between trainees. So I work at the QE hospital in Birmingham, one of the sort of most affected hospitals in the country by COVID, and our training within our specialty has been pretty decimated, but I know some of the other training units around the region have been a bit more fortunate. Also, some units were slightly better or worse affected in the first wave compared to the second wave, so there's been a huge variety. And we know, because we've heard again already, that this is mainly related to a significant reduction in both operating, but also all the other things that are involved in training, so outpatient clinics, MDTs, all these other learning experiences. Obviously, our specialty, as we saw from Professor Lund's graphs earlier, we do have quite a lot of emergency work, and that largely continued as normal, although we did see a reduction in numbers, both numbers presenting to hospital and the numbers of cases that were then managed operatively. So, things like burns, lower limb trauma, hand trauma, soft tissue trauma and infection makes up quite a large amount of our workload, and we're lucky that that carried on, fairly normally. Some of our elective work continued. So again, a lot of our workload is cancer related. So we managed to continue some of that even during the biggest peaks of the pandemic. And we know that some of that moved into the private sector. But I thought what I'd do as well is just touch on some of the positive effects. If, I struggled to draw this list, but I think there were some positive things that have come out of the pandemic. A lot of our trainees were redeployed to other areas. And certainly within the QE, the feedback we've had from our trainees, from their flexibility, their willingness to get involved in whatever needed doing was just fantastic. So I think a lot of us have had the chance to develop new skills. These won't necessarily be operative skills, but some of the non-technical skills, team working, being flexible, working with other perhaps specialties and teams that we might not have normally had the chance to work with. And part of the new curriculum involves inter-specialty CBDs. So, maybe some of the links and relationships that you've built up during your redeployment might help with things like that. I think a lot of you have taken the chance to, perhaps while surgical activity has been lower, to maybe work on some of the non-surgical curriculum requirements. So get on doing audits, writing papers. Trainees in the West Midlands have to do things like modules, working towards the exam. So, this has been a relatively good time to get on with some of those. And actually, the vast majority of our trainees, both at the ARCPs in July last year and January this year, still got outcome 1. So, you've all worked incredibly hard to still be able to meet your curriculum requirements, despite all the difficulties that have been thrown at you. So I think that's fantastic. And our trainees in the West Midlands, at least, have found that surgical experience in the private sector has generally been really positive. I've seen one of the comments in the chat box about some trainees having limited exposure, but actually our trainees found that those lists were packed with great learning opportunities. They didn't have the normal day-to-day distractions of, being called to outpatients or being called to the ward or having to review something that was going on in the hospital. They literally just had lists that actually ran very efficiently and maybe had 3 or 4 major cases on, whereas perhaps on a normal NHS list, you might just have one of those. And they found that they were really getting sort of one-on-one consultant training without all the other distractions. So actually, we found that really positive. We've had fantastic experience using the PGVLE system for all our regional teaching, which is now completely online. And I think that's made the regional teaching more accessible to our trainees. I think that's been a fantastic experience. And as we've seen tonight with this webinar, there's now such a huge amount of teaching, webinars, all sorts of things that go on online. Many of these things are recorded, which means that they are more accessible. And I was really impressed when I was doing the ARCPs over the last 12 months by the number of teaching opportunities that our trainees have managed to get to, like dozens and dozens and dozens. Some run within the region, some national, some international. So I think these are positives that can be taken away, which will hopefully mitigate slightly against the very significant downside. So training recovery, I think we are hopefully all seeing a slow return towards normal. Obviously, it's going to take a long time. Increasing amount of elective work is now being carried out. And again, that still varies a lot between hospitals. But as we've heard, this is going to be this huge backlog of cases, these 4.5 million patients on the waiting list, which will take some time to catch up with. So we might need to just be a bit more flexible about our training opportunities. It might be that not all of these lists happen Monday to Friday, 8 till 5. They may not all happen in the NHS sector, and we might need to look at trainees moving between units or possibly the rota being a bit more flexible to allow exposure to all these training opportunities. And I think at least in plastics, many of our indicative logbook numbers, the indicative cases that you all need for your CCT, are related to trauma or cancer. So as category 2 and 3 work restarts, you should be able to pick up most of those numbers. Some of them that are more related to category 4 elective work may be more of a struggle, but I think they will be relatively small numbers. In the West Midlands, we've been setting up a series of microsurgery labs, so we're not quite there at the QE yet, but the other 4 training units in the region have now got dedicated microsurgery labs, not only open to plastics trainees, but also max facs, potentially also general surgery, vascular, any other specialty that finds that useful. So when you can't perhaps get into theatre and get those practical experiences, we've got simulation and other ways of trying to keep those skills up so that when elective operating does restart, your skills are hopefully as fresh as possible. And just to reassure you all that obviously, as we've heard with these ARCP outcome 10.1 and 10.2, these do take into account the effects of COVID. Nobody's going to be penalised if you haven't met your curriculum objectives because of COVID. So those derogations are likely to stay for some time. And my final slide, what next? Well, I wish I could tell you, so probably none of us here really know. We've heard about the new curriculum and the fact that that is now more outcome-based than time-based, so potentially that's a really positive thing. All of our trainees will have a personalised trainee recovery plan, so they'll all have a one-on-one meeting with one of the trainers to discuss the effects of COVID on them specifically in their training, so we can look at individualised plans to help you recover your training. Some people will need their training extended, but actually I'm hopeful that a lot of you will catch up, and we're in a very fortunate position in the West Midlands at the moment. In many of our trainees are relatively junior, so they've got quite a lot of time to catch up. But of course, we don't know, will there be a third wave, a fourth wave? Who knows? But all I can say is that we will do everything we can to support you. And as I find out information, I'll pass it on to you. And I'm very happy to take any questions.
That's brilliant. Thank you, Liz. That's really helpful. What I might do is get all the TPDs to run through their slides, and then we can have a free-for-all with the pre-submitted and the written questions at the end, if that's okay. There's nothing specifically plastic been typed in while you've been talking. Excellent. So can we now go to Andrew Robb, please, who's the West Midlands TPD for Paediatric Surgery. Thank you very much for coming this evening, Andrew.
Cool. Thanks. Oz, can you put up my slides, please? Perfect, thanks. So hi, my name's Andy Robb. I'm one of the paediatric urologists at the Kids Hospital, and I'm the lead TPD looking after Bristol, Birmingham, and the Cardiff Paediatric Surgery Training Consortium. Next slide, please, Oz. So PEDS has been a bit sort of protected with the pandemic, with COVID not actually affecting a lot of our resources, but the staffing and the hospitals have been significantly impacted, with staff being redeployed and us not being able to carry on our normal workload. So we've seen a significant decrease in our elective capacity, and that's mostly been around the smaller cases that can wait. So the stuff that the very sort of early years regs need to get their a hold of. We've seen an increase in the total number of kids waiting for surgery across the region, and the wait for surgery has gone up, and the Midlands is in quite a bad position across the UK for that, and there's a lot of work being done in how we recover. We're also seeing a lot of the adult units not undertaking general surgery of childhood, so that puts a lot of pressure on us to try and identify opportunities for not just paediatric surgical trainees, but the urologists and any general surgical trainees to get a hold of childhood operating. But in a way, this is also a really good thing for us and gives us some opportunity, because we're going to see a lot more of these smaller cases. We're going to have to find ways of managing that, and that is going to present potentially opportunities for us to offer that training out wider than just paediatric surgery. Next slide, please, Oz. And moving forward, people have been, I'm sort of, Jonathan Lund has already mentioned a lot of this. So we've got a new curriculum coming in for any of the peds surgeons that haven't got it. If you click that QR code, you'll get the new curriculum. Next slide, please, Oz. And it does change the way that we're going to be training. It's going to be competency based, as already been said. But given the number of cases, index cases that we have in paediatric surgery, that's going to remain a challenge for us trying to get those for our trainees. Next slide, please. And the other thing that's changing is that we're getting the competencies in practice. And for paediatric surgery, we've got a very specific one of managing an infant or child in an ICU environment. And that's going to be the sort of place that we're going to be looking for cross-specialty CBDs. So working with the PICU consultants and the NICU consultants. And for we're starting to look at run-through training. So we've got a run-through pilot program starting in the West Midlands, which is going to incorporate NICU as part of that. So by the time that person starts their reg training, they're going to have had NICU experience. So hopefully that'll facilitate that. Next slide, please. And then we've got the multi-consultant reports, which are going to be key for ARCPs. Next slide, please, Oz. The other thing is there's going to be some other disruptors around for paediatric surgical training, which means that exactly the format of training over the next 10 years is going to change rapidly. We're still waiting for the official publication of Getting It Right First Time, but it has been made available within the NHS. And it's going to have a significant impact potentially on the configuration of services and how we deliver training, because cases and case mix are going to change dramatically if all of the recommendations within that document go through. And it's also going to change the clinical skill set that we require from newly appointed consultants over the next 10 years. Next slide, please. And the other thing that has become very apparent is that we're not able to train people to provide a subspecialized service at the end of their NTN training. And there is going to be an expansion. There has to be an expansion of post-CCT training for some of the fellowships and some of the specialized subspecialty work that we do nationally. And there are some fellowships emerging. So Peds Urology fellowships, the Colorectal Fellowship in Chelsea and Westminster, the Minimally Invasive Surgery Fellowship in Edinburgh. So one of the challenges that we're going to be looking at is how we actually address that and make trainees sort of streamline into those fellowships as time goes on. Cool, that's the end of that presentation. Thank you.
That's great. Thank you very much. That was fantastic and very succinct, which is helpful. Cheers, Andy. So we're going to move on now perhaps to Rob Williams, if that's okay. I think it's going to be brevity personified. Is that right, Rob?
Correct. If you thought that was succinct, I've only got one slide. And I put this up really just, I mean, I suppose it's slightly superfluous because of John's Lund's excellent data, but the sort of problem that's been highlighted to me most frequently is trainees worrying about their logbook numbers. So I did a bit of work a few years ago about winter bed pressures, which is why this dates back to as far back as August 16, but it just shows you trends over time. So the blue line is the mean number of logbook cases. So historically, we've had about 150 cases in logbooks over 6 months, which dropped to about 120, which is then became the new average. We're down now to an average of about 100, but it's quite patchy. So about a third of trainees have had no change in their logbook numbers, and then some others have had more significance. About 45% of trainees have had either well, as much as an 80% reduction in their logbook. So it varies from 30 to 80% in that 45% of trainees. So I brought this up really just to highlight that I think, you know, some of the trainees locally have been wondering whether there will be a sort of blanket policy applied, which I'm against. I think it would be a bespoke policy, as you've heard other speakers talk about, but also adjustments to training timelines. I think may come not now, but actually quite a bit later in the training timeline, when we know how this distills out in the sort of in the bigger picture. Numbers themselves were only ever indicative and have been removed globally from the general surgical curriculum. So it really remains to be seen how this translates to competency changes. We'll just have to see that as it comes through, really. And then the endoscopy challenges was the other thing I was going to bring up, which I've kind of touched on. And I think we will be needing to use passports to move trainees to higher volume units, and again a bespoke approach is going to be needed, and we'll have to work on that as we go through, really. Okay,
that's great. Thanks, Rob. And then our last TPD speaker this evening. We have Andy Garnham, who's going to speak predominantly on behalf of vascular surgery. Thanks very much, Andy.
Thanks, Jill, for inviting me. I didn't put up any slides because I didn't know what everybody would talk about beforehand, and I think a lot of the issues have been aired already, but we've been running a joint vascular education and ARCP programme across the East and West Midlands, which I think has been great. And I want to thank our trainees really for being very engaged in taking us from a monthly education programme to taking it all online. And I think as trainers, we've learned a lot about online teaching, and we're running slightly shorter sessions because you can't run the same level of sessions, but I think we've actually successfully taken a lot of our training online, and that's in no small part Oz and the trainees, really. In terms of logbook numbers, with vascular, we've been relatively preserved with our emergency caseload, which is a large part of the work, and I know people are worried about their aortic numbers, and I think what John said earlier is really important. I think we must make every case count as a training case, and I think avoid those service pressures and be quite astute at making sure the timetabling is right for our trainees. With the training days, we have missed out on some of the simulation and practical things, and I think as things open up, we need to get that back online. I think the ARCP process this year, when we took it online, was actually a positive, because we hadn't got trainees travelling to a central location and taking a half day out to actually come for ARCPs. And I think there are some positives we need to take out of this. I think the new curriculum is key, and it's the same for vascular surgery as other specialties. And one of the things I thought we ought to point out to trainees is that actually we've got an education supervision in practice course for trainers who might be less au fait with the new curricula than they are as trainees. And we are going to run a number of those. And Adam Farquhar, and I know, is on the call, who's worked with me and others to set up this for the trainers to make sure they're all au fait with the new curricula. So I think we want to help trainees get the most out of that. So I'm going to stop there, and I'm happy to take questions.
That's great. Thanks, Andy. I'm having contact from, we were supposed to have cardiothoracics this evening. I've just been messaged to say he's actually had an unexpected family issue and can't make the Monday one either. So if there's any particularly cardiac directed questions, we've got the esteemed Mr. Graham on the call with us this evening. So please feel free to type in and pick his brains live, unprepared. That's, people pay for that. Don't know if you want to say anything, Tim, particularly about cardiothoracics.
Well, you'd see from the previous data, it's been very, very badly affected in terms of elective cardiac surgery. They've tried to tick over with emergencies and emergent work, but elective surgery has been very badly affected. I know, for example, in my own trust, UHB, there's been direct conversations between the cardiac surgical team and the chief medical officer today about accessing ITU facilities. It's still very difficult for the super specialties that have got a large ITU requirement to get access to ITU for elective surgery. So that includes cardiac, sort of exotic hepatobiliary practice, and of course you saw the impact on elective neurosurgery earlier. So interestingly, thoracic surgery is not being quite does not seem to have been affected to quite the same amount. One, because of the preponderance of cancer work, and two, because they don't have quite the same requirement for ITU facilities post-operatively. But also in terms of the West Midlands, the prediction is that cardiothoracic surgery would potentially, as a percentage, have the largest, a large proportion of trainees potentially requiring a degree of extension of training, again due to that lack of experiential training in cardiac surgery. So.
Okay, thanks for that, Tim. What I plan to do now then, we've got up to 30 minutes left. I've encouraged people please to type anything in the chat bar that you want while you've got a captive audience. We have lots of pre-submitted questions, so I will throw those around, and if we could be as brief as possible, we might get as many done as possible. So, Mr. Williams, a general surgery question. Have you got any comments on a pathway for hepatobiliary training in the new curriculum? You're going to change your placements, do something different?
I think it depends on how your rotation, how your HPB firms are fitted within your rotation. So in my own region, we've got one centre that does all of it. So actually, placements for that is very straightforward, because you go to that unit, in that phase, certainly in that phase 3 section, and probably as a taster in phase 2, I would suggest.
Okay, fine. Mr. Garner, we've heard about this a bit from Ballot in the West Midlands, endoscopy training in particular. Any strategies for the West Midlands?
So I think what we're looking to do is look at the opportunities that are out there. And we know that there are some units that don't get trainees to their lists because they are in other hospitals. And I think we need to use that resource around the patch, and we're in the process of doing that, and we want to get a lead at the general STC to champion that.
Okay, fine, that sounds like a good strategy. Difficult one for Mr. Graham here. So trainees at the end of training who've been redeployed on more than one occasion, are they going to get additional time, and how much additional time are they going to get?
Well, it'll be on a case-by-case basis. It will involve one-to-one senior educational supervisors, either the TPD or a nominated member of the training committee or AES, having a granular, bespoke conversation with each trainee to essentially look at the gap between where they are and what they require, either to achieve an ARCP1 in that indicative year, or to achieve a CCT. It's difficult to give an overarching answer to that, except every trainee will be considered with a TPD. The anticipation in the West Midlands is that the TPD will be overseeing that process, if not undertaking the conversations directly. The key reason for that is because the TPDs are the ones that have the knowledge of the rotations, and they're organising the rotations on the programs is a little bit like moving the yellow square on a Rubik's cube and trying to get it back to where it was originally. Because once one trainee doesn't move, then it has a knock-on effect on everybody else. So that's why I let the experts do it. Okay.
Thank you for that. One to Mr. Williams. They've noticed in the new general surgery curriculum there is a training pathway for trauma surgery. How are you going to manage to accommodate those people that declare that then?
So I think within our own region, so we're divided into north and south. We've got an MTC in the north and not in the south, and we will be needing to move trainees around the region to accommodate that. Really, I think it's always very helpful if you know that declaration nice and early, and then it's just about planning.
So I think that's key actually to all of this, isn't it? Communication. So a little bit more active communication and declaration rather than sometimes we just sail along, don't we? Difficult one again for Mr. Graham. So West Midlands has been really hit by COVID. We heard that in the core events that we ran as well. What is the deanery's plan to compensate everybody for that absolute lost year? Because they've all had a lost year, many of them.
I'm afraid it's the same answer as before, which is it will be a one-to-one conversation with each trainee to identify the gap between where they are to get an ARCP1 or to get their CCT. I'm afraid there's not a one-off answer. HEE, the country can't afford for every trainee to have extension of training for a year, and also we have to consider what's going to happen in terms of recruitment. We can't jam up recruitment into surgery this year completely, so it has to be essentially a one-on-one solution as best we can. And that issue that Phil Bright raised about competence versus confidence is very relevant, particularly in the latter years of training. And I know that you're trying to move me on, but I'm doing what the politicians do on Newsnight, which is trying to speak without breathing. Yeah, and you've got, yeah, and Laura Kussenberg's going to cut me off. Yeah, okay, there you go.
For Ms. Chip, please. Impact of the new plastics curriculum for August 2021 and CCT requirements. How will that be implemented for the senior trainees who so far have been working towards the old CCT requirements? Any special plans or differences that will have to be made?
And so I think, as we heard earlier, if they are in the last sort of year or so of their training, then they can choose to remain on the old curriculum and continue to work with their curriculum requirements. Similarly, those who are LTFT will have the choice to do so. Otherwise, particularly the trainees in our region are mainly fairly junior, so the majority of them will move across to the new curriculum. And obviously, we'll look at what curriculum requirements they've already met, what competencies they can take forward. And, you know, again, with planning and rotations and the various placements to make sure that they get the right learning environment to meet all their curriculum requirements. And we'll discuss that again on an individual basis with each trainee.
I think that's key, isn't it, those conversations. Mr. Garnham, how would the deanery help a trainee who's coming back from UPAR? So they went out when life was normal, they've had 3 years out and they're coming back as an ST6 with only 2 years to go, totally new curriculum.
So I think it's very important to have those discussions ahead of time, and we see the trainees regularly as part of UPAR. They get their keeping in touch days to come back and look at clinical things, and we need to plan their training requirements. So I think, again, as Tim quite rightly said, a one-to-one conversation and some protected time. And occasionally we need some bedding in time off rotas when people come back into programme. So we've done a number of things, but it's very trainee specific.
Okay, one for Mr. Lund, who I saw briefly like Banquo's ghost. Has he come back? Is he there? He's gone again, hasn't he? Okay, thank you, John McGregor. John McGregor is leaving us. John Lund has hidden somewhere.
Jill, just to add to Andy's comments about trainees coming back from OOPS, remember that there's professional support and welfare unit, and there's a supported return to training budget across HEE. So any trainees coming back from these OOPS that are deemed to have particular needs or may be particularly disadvantaged, then there's an option for them to have a supported return to programme, even a phased return. So please please engage with your TPD and the local professional support and welfare unit who has a supported return to training programme and potential budget.
Okay, I don't know if Ms. Chip, do you know anything about the changes to TIGs as a plastic surgical TPD?
Yes, unfortunately they're ending or have ended. I think the people on current TIGs are finishing and there won't be any new appointments, unfortunately, which is a big loss. I don't think there are any plans to replace them at the moment.
Oh, can I come in there?
Oh, his voice. Yes, go, Mr. Lund.
Yeah, sorry, I'm having an absolute Teams nightmare, but I can speak. TIGs, the TIGs are interesting. They've been part of the curriculum since 2003, perhaps before for some of them. The GMC didn't know they were there. When they found they were there, they didn't like them and asked us to move them to the postgraduate arena. So in essence, what's happened, the TIGs are staying exactly as they are, but they're becoming immediately postgraduate as in contrast to where they are now in that slightly odd put your CCT back until the end of the TIG thing. So the TIG syllabus is remaining exactly the same. In fact, we can, because of the change in general surgery, we can probably upgrade the oncoplastic breast TIG and the trauma TIG because their syllabuses are contained now entirely within general surgery. So for plastic surgery, it's great news. There's no change to the TIGs. Then plastic surgery involved in more than any other specialty. There's no change in the TIG opportunities for people becoming plastic surgical consultants.
Okay, there's a specific one that I think I know the answer to. I'll just maybe check with Mr. London, Mr. Williams. ATLS incredibly difficult to get on with long waiting lists. Any moves to allow more surgically relevant courses such as European trauma course to count?
It's all about equivalence. So European trauma course will count, DSTS, and any locally provided course that has the same equivalent educational outcomes.
Yeah, it's possible to put a sort of portfolio together which shows equivalence.
Excellent. I think, we've 15 minutes early ahead of time. We've got nothing else live typed in, and these questions are all the same themes. The themes are very much about logbook numbers, operative experience, and will I get the extension that I require? And if so, how? And can you be a little bit more structured with my training because I'm going to miss X, Y, or Z? Suddenly seeing some more questions, as we said. So yeah, absolutely. Oz, who will provide the accreditation of the equivalent courses? Mr. Lund or Mr. Williams?
So I think that's it probably comes down to looking at what's contained in the sort of portfolio that's presented. You could do CBDs related to trauma as well, and it'll come down to what the SAC reps and the TPDs set as a level. Really, I think the SACs need to be involved so that it's applicable across the nation rather than just a local glitch.
Okay, I think we've got nothing more typed in. We've got repeated questions on the same themes that everybody's addressed already. Sorry, there weren't any more particular paediatric surgery ones. So I would say the big themes are logbook numbers, operative exposure, extension of training, absolutely sensible ARCP panels. Thanks, Bala, for that, totally. Themes seem to be communication. Yes.
I might just say, I think we, as a group of trainers, would probably want to just say that we have recognised the huge amount of hard work that our trainees have put in over what's been a hugely difficult time for them, both within their own training, but also to support the NHS as a whole.
Yeah, absolutely agree. And I think we're all in it together. Please don't ever feel otherwise, definitely. And that's why everybody's here trying to help. So yeah, communication, collaboration, pan-Midlands approach, training passports, your individual needs to be recorded and then addressed on an individual basis. And we will all do our best to try and get everybody to where they should be. On that note, does anybody from the panel, Mr. Graham, do you feel the urge?
Well, in line with what Rob said, I'd actually like to thank the trainers and particularly the TPDs as well, not just the ones here, but across the whole of the Midlands. It's maybe not always apparent. We're a little bit like ducks on the canal, but our feet are frantically going underneath us, and it is an ever-changing situation. So don't forget, be nice to your trainers. Trainers get tired too. The trainers do want to train. They're in a really difficult environment if they're coming back from a period where they've not been doing a lot of operating. So it's just about communication and just maybe trying to put yourself in the trainer's shoes occasionally, and everybody trying to be reasonable with each other and having reasonable levels of expectation. Thank you to the TPDs and all the trainers.
Last minute typed in question from David Nauman, who has been very active with his questions this evening, saying, why aren't the training checklists on ISCP as an easy to use online form? Mr. Lund, you've some familiarity with ISCP?
Yeah, I don't think they're that tricky really, and they're going, so
okay, so
good question, perhaps a bit late.
Anymore, so they're not going to, and they are on the JCST website, Bala, that is correct, but I think they'll leave. That's really useful. Right, the same event is going to be run on, what day is it today? Wednesday or Monday evening, with the other surgical specialties predominantly who aren't represented tonight. Anybody who wants to come again, feel free to come again. There's a registration link that Oz has put out to everybody. Opportunity to submit questions in advance, questions live, anything you didn't feel was addressed properly that you've had a bit of a think about, you want to put in more detail. I have nothing else to say. Thank you to everybody who spoke. I think our big hitter national people have all left, apart from the silent voice of Mr. Lund. Local TPDs are still here. It's a good night from me and Mr. Graham.
Yeah,
Good.
it's good night from me, and it's good night from Jill. Thank you, Jill. Good night, everybody.
That feedback form that I've put in the chat box.
Yeah.
It's important we get some feedback so we can try and make this better for next time.
Okay, thanks, Oz, and thank you for Steven Spielberg in the background. Thanks, Oz. Okay.